So my name is Dr. Susan Coffin. I'm an infectious disease pediatrician who works at Children's Hospital of Philadelphia in the Philadelphia Department of Public Health. And I have an area of expertise in infection control. And so as you can imagine, I've been quite busy with the coronavirus responses, both at our hospital and throughout our healthcare network in the city and throughout our region. I'm also very involved with the CHOPS Policy Lab, and I'll throw it over to Dr. Meredith Matone, who's one of the scientific directors there, to introduce herself, and then we'll jump in and share with you some opening comments.
Great. Thanks, Susan. Good evening, everyone. I'm Dr. Meredith Matone. I'm an epidemiologist and public health practitioner by training, and as Susan mentioned, I'm the scientific director for Policy Lab, which is a research center at the Children's Hospital of Philadelphia that has been doing a lot of partnered work with the state and city and other stakeholders in the community to help support sort of the translation of knowledge, what we know about coronavirus in children, to decision makers at sort of the local and state level. And so been working closely with Susan, and we've put together some guidance around school reopenings. And so we're happy to be here with you and speak about some of that guidance this evening.
So I'll jump in. Meredith and I together have done several conversations with various school boards and school-related entities. What we have learned is that the questions that are being addressed and dealt with by school boards have a lot of similarities, but each community is different. And so I thought I'd open with just some comments about where we think your community is in terms of the burden of disease, because I think this really is one of the key factors that should guide decision-making now and going forward about how you think about the right balance between in-person education and all of the benefits that that provides and at-home instruction with all of the safety benefits that that provides. So right now, we know that there have been about 10,000 cases in your county. There have been almost 700 deaths of people in your county, which is considerable. And this is really a huge loss. I think the good news is that the rates are going down, and they're going down significantly. One of the things you'll hear us speak about in the next couple of minutes is how we use the current burden of disease to guide decisions about what are the best safety practices, in our opinion, to move forward with decisions around in-person and distance learning. So right now, the estimated 7-day incidence of infection, which means over a course of a week, how many people get newly infected with coronavirus, is 81 per 100,000. Just keep that number in mind, 81, because you'll hear us come back to that. And then also the other measure that we use to try and get a sense of the burden of disease in a community is what is the proportion of people who get a coronavirus test that test positive. Test positivity rate is how we refer to it. And that rate currently is about 4.8. So both of those numbers are a little bit higher than what we're seeing right now in Philadelphia proper, but they're both coming down gradually but steadily. And so that's the good news. So one of the most common questions that Meredith and I get asked is, what does it take to reopen schools and to reopen them safely and to really achieve what I think all of us agree is our ultimate goal, which is not just to reopen, but to keep schools open and to launch a successful year of learning and a successful year of instruction on behalf of both students and teachers. And so we've kind of distilled it into a set of recommendations. The first is that we need to really achieve good viral control in the local community. And we'll talk more about actual numbers that we think can serve as guideposts for you as you think about where your community is now and where it is headed towards in the coming weeks. The second is having really good school plans, and not just good school plans, but actually well-resourced plans, so that we're not just talking about we're going to have 6 feet of distance between students in a classroom, but actually having the plan that maps out to providing that 6 feet of distance, if that's what your goal is, which we think at the moment that is the right goal. And then the last is really having the confidence of your community, the confidence of your teachers and staff who will be spending so many hours in school, and then obviously of the students and their families. I think confidence really may, in the very end, be the thing that makes or breaks success. So one of the areas that we'll dive into a bit more deeply as we go on, and certainly happy to answer questions with, is what does a good school plan look like? I think it starts with a really nice partnership between parents and the school administrators in a good screening plan, which entails that both the parents and students are doing a daily check to make sure they're well, they haven't had an exposure in the past 24 hours that's concerning for coronavirus, and they really are ready to go to school, learn, and to ensure the safety of the other kids who are going to school and the teachers. On the flip side, we need to have our staff and teachers doing the same. And there are a variety of ways we can get to a good self-screening plan, but I think screening is really essential. Once people arrive to school, school's going to look different than it has in the past. It's going to entail masks on virtually everybody. There may be short mask breaks, but it really shouldn't be extended periods of time without a mask, at least in the early fall while we're still really struggling with getting good viral control. It's also going to include social distancing. So just like we're doing while we wait in line at the grocery store, we need to build classrooms and spaces within schools that allow us to keep significant distances between students and teachers. And then finally, it's going to entail a lot more cleaning and attention to hygiene, cleaning of hands more frequently than just before and after eating and after using the restroom, but also periodically during the day as one of the strategies to help reduce transmission. So that in broad brush strokes are some of the things that we're thinking about are good core principles for you to be adopting and embedding, as I'm sure you have already, into your reopening plans, and that should guide your decision making. But I'll throw it over to Meredith to make some more comments with some more specific ways to think about this.
Sure, thanks, Susan. So I think just to sort of dive right into a question that was raised around contact tracing, I think that plays really nicely into the overview that Susan just provided around a partnership between families and teachers and the school administrators around a sick policy and sort of a daily screening. Contact tracing serves the public health function of identifying the social contacts of someone who has tested positive for coronavirus or is a probable case. And that's really something that is going to be taken on by the public health department. And so I would add that in addition to really thinking about school reopening and the success of school reopening as a partnership between families and schools, likewise, it's a partnership between schools and county health departments who are going to be your support system when you have an individual that identifies as testing positive or identifies in that daily screening as being symptomatic or having a direct exposure to a COVID case. Those are the times in that sort of daily screening that you're going to want to get on the phone and call the Montgomery County Health Department or the State Department of Health once you've identified your sort of appropriate point of contact. And I think that the Montgomery County Health Department and the State Department of Health are sort of working out right now what those roles and relationships are. But I would encourage you to understand who your point of contact will be, because you likely will have sort of frequent engagement. But in our state, the Department of Health and the county public health departments will assume responsibility for that contact tracing. Now, you may decide that there's sort of an additional layer of communication around test positivity and exposures that you'd like to take on within your schools and between schools and families. But the actual work of contact tracing will not be part of your responsibility. So hopefully that offers some relief, but I would encourage you to identify that appropriate contact and what that communication plan is going to be when you do. And it is likely inevitable that you will have someone, either staff or students, identify in that daily screening as being symptomatic or of having a direct exposure. And the health department will really be your guide on what to do in terms of next steps. So beyond that, Susan opened up with some comments about the rates of community transmission in Montgomery County. And what I would like to do is just to spend a few minutes talking about how to think about those rates of community transmission and what they mean for in-person versus virtual learning. And then we can open it up for questions, because maybe we did and maybe we didn't sort of hit on the things that are pressing on your mind. So as we have assessed the data that we do have, and we don't have all the data that we'd like to have, but as we've assessed the data that we do have on children and coronavirus and on school reopenings, we have seen a consistent theme. And this has really been reinforced in the past few weeks as schools have started to reopen in this country in areas with higher transmission. And we've seen the overall sort of lack of success or less success than we would have liked with that. And have developed a set of thresholds that are informed both by our expertise as pediatric health experts and infection control experts, as well as the data that we have from places that have been able to open schools and open schools in a sustained way. And those some countries abroad. And the thresholds that we've identified for safe reopening are 10 per 100,000, a weekly average of 10 per 100,000 new cases each week. And as Susan mentioned, I think the rate that you're looking at right now is 81. And so this is outside of the threshold for which we would consider feeling totally comfortable for full in-person instruction. The test positivity rate is another sort of metric that we consider. And what we'd like to see is a test positivity rate of less than 5%, which is achieved in Montgomery County. And the other sort of third and really one of the most important sort of signals to think about is what is the trend in cases. And in Montgomery County as a whole, I would say that for a long time the trend has been going down. There's been some recent blips, and it's hard to tell exactly sort of what is going to happen. But I think we are cautiously optimistic that after we get through the Labor Day holiday, that we may be able to sort of return to the sort of long-standing decline that we had been seeing in Montgomery County. When we look at Royersford and Limerick, I would say that what you have going for you is that there have been fewer cases and a lower overall case incidence than the county as a whole. The last 2 weeks weren't great for Limerick. We did see a rise week over week in the cases for Limerick. So I think it's something to watch. But as we think about case incidence and school reopening, what we really want to see is a sustained, so a week over week decline in cases that's achieving a level of case incidence that is closer to that 10 per 100,000 weekly case incidence average. And we know that there are populations of students that really are sort of disproportionately impacted by virtual learning, and that would be students with learning differences and those who are our youngest sort of elementary age students. And so within our guidance, we talk about a framework for thinking about how to have sort of a staged return to school. And one that would prioritize thinking about those special populations and maybe being able to sort of bring those populations back before a full in-person return, and that there would be a wiggle room to sort of do that as we think about incidences that are a little bit higher, so between 10 and 35 new case incidents for the week. And so I know that some of this is getting a little technical, and I hear myself, so I'm going to stop, and why don't we answer questions?
First, I have a few questions. Well, thank you very much. It was very helpful and very informative. And I do want to start off by saying that, you know, the 700 deaths in Montgomery County are extremely unfortunate, and no one wants to see anyone passing. My sincerities go out to all the families that have lost loved ones, because it is unfortunate, and we would hate to see that happen. But you threw out some numbers. So I just want to make sure I understand the numbers. So, because these numbers, this is what will help school boards, as you mentioned a little later on in the presentation, this is what school districts are going to try to, at some point, decide or figure out if and how we could bring the kids back to school. So again, thank you for that. So you were saying that since the COVID started, there was 10,000 cases that tested positive. Is that correct?
And in Montgomery County, that's correct.
Yeah. Pardon me?
In Montgomery County.
In Montgomery County, right. Everything's going to be in Montgomery County.
Sure.
And then of that, there's 700 deaths, right?
I actually need to apologize. I transcribed the numbers. There are 861 deaths being reported.
861, okay. Okay. Do we know of the 861, because there's been all kind of numbers that have been thrown out there, but of the 861, do we know how many of those were in retirement communities and veteran homes?
We do not have access to those data. Those data will be held by York County Department of Public Health.
Okay, because at one time there was a report that was 60 to 70% of the deaths in Montgomery County related to nursing home and veteran
it certainly
centers.
Represents a substantial proportion. Whether or not it's that large, I'm unsure.
Right. Do we know of the 861 deaths what the average age of the deaths were?
I certainly don't, but I do think that it would be skewed strongly to the older age group. We do know that people who are elderly suffer the most, as well as people who have chronic health care conditions. Fortunately, children are relatively spared, both from severe disease and definitely from fatal disease.
Right, because that was going to be my next question. Do we know how many people of the 861 that passed had another condition, a primary condition that potentially could have been the cause or led to the cause of?
So, I would be glad to point you in the direction to get those answers. As pediatric experts, we haven't prepared ourselves to provide answers for those sorts of statistics, but I suspect they are available on Montgomery County or the PA DOH website.
Okay, so then
I'm sorry, I was just going to say, I just pulled up, and Montgomery County has a terrific website that I would encourage you to take a look at. I would say that in looking at the data for Limerick, because the sort of Springford area is not an area that is heavy with retirement homes in comparison to other townships and municipalities within the county, that the average age of cases in Limerick is 43. So I think it skews lower in your area. That said, as I mentioned, I do think that it's important to consider local, very localized trends. And I would say that case incidence in your municipality has been lower overall. But as I mentioned, there has been a very recent uptick that I think bears watching.
Yeah, and I could pretty much tag what that increase has been related to in the area with all the. I'm not going to go into that. But so from a pediatric standpoint, then, and what you're seeing at CHOP, what's the infection rate in Montgomery County that you're seeing from, say, 18 and less?
So we don't partition our data at CHOP by county, but what I can tell you is that overall we have a positivity rate around 5%. We need to remember that proportion, the children who come to CHOP for testing are not the same as the children that would be coming to school. They're medically complex. They have many contacts with the healthcare community. So we're hesitant to generalize and say that means 5% of the children in your township are likely to be infected.
No, that's a great point. And because I was going to lead to my next question of if they're being tested at CHOP, is it because the children are there for another reason, or do you have a center set up just to help test children?
The answer is both.
Okay.
So when a child needs to have a significant medical procedure or hospitalization, they almost always will get tested, whether or not they have symptoms. We also have several different ways to test children who don't require hospitalization and test children at a variety of the different CHOP-related practices and some drive-through centers based on the symptoms that they have. So we've got a data from a diverse group of children.
And then just my last question, and again, the information provided was extremely helpful and informative. But my last question is that I guess as I'll speak for myself, I kind of struggle with everyone wears a mask, and then we're required, or not required, but it's recommended that there's a six feet distancing. But my question is and again, and you don't have to answer from your professional opinion if you don't feel comfortable, and I totally understand and support that. But in a classroom environment, if the kids are seated at their desks and they're wearing their masks, would they still need to be socially distanced at 6 feet, or because of the wearing the mask and all the other things that are taken into consideration, would that be something that we could consider having a smaller footprint around the students?
Sure. This is really one of the most challenging questions. And it's not just challenging for your district, but for all public school districts, is how to think about a safe amount of space. The ideal is 6 feet, and I don't think we should lose track of that. In point of fact, what we have, though, is a system of infection control protections for teachers, staff, and students that are layered on top of each other so that each adds to the degree of protection offered by another strategy, and none are 100%. So in that way of thinking, we know we get a lot of protection from everybody wearing their masks and wearing their masks appropriately and wearing them constantly, but we don't get 100% protection. Similarly, in an indoor space for an extended period of time, we get a lot of protection from having people spread apart, but we know that it's not 100% protection. And we certainly know that it's very difficult for hours on end to maintain an absolute 6-foot distance between people. And so as we think about these protections, what we think about is that we have goals and ideals, and we want everyone to be adhering and pushing as hard as they can towards those goals and ideals. But we also recognize that we need to get children back into the classroom but we want to challenge ourselves, and we challenge ourselves in our setting and in our discussions with other school districts to get as close to 6 feet between students during a time while we still have significant viral activity in our community, and challenge ourselves to make good use of extra space like cafeterias and auditoriums and gymnasiums that may not be used constantly during the school day. And so your schools best. You know where those extra pieces of space are. You know where what may be and may not be possible. But those are the principles that we would like to share with you on which for you to use to make your specific decisions for your school system.
Yeah, no, that was extremely helpful. So thank you.
Thank you. I also, and as Mr. DeBello shared, your presentation was very helpful and very informative, and gave us a lot of key points and resources. So I thank you both. I did have an additional question, and really a lot of it was taught when you were sharing about screenings and student screenings and family screenings and staff screenings. Obviously, we see at this time, a lot of allergies. So there's this confusion between the runny nose, the sneezing, the cough, is there any, I don't know how to say it otherwise, but any better or more clear guidance that we can utilize to help better identify those instances that are truly symptomatic versus somebody who is just catching a common cold? Or, because again, exclusion is a tough pill to swallow when you have to pull a student or a teacher out of a classroom for a period of time.
Right.
And that's certainly something we want to try to minimize, but we want to do so if we need to, and we want to better understand that differentiation.
The challenge that you're struggling with is one that we're struggling with in virtually all settings, whether they're pediatric or adult, community or healthcare. We don't yet have a firm enough grasp on the exact constellation of symptoms associated with coronavirus to be able to have a really crisp definition that clearly differentiates it from things like allergies or chronic asthma. The guidance that I've been sharing with our general pediatricians that may be useful here is that this is really about a difference from baseline. And so if there is a child who at baseline has well-controlled asthma or well-controlled seasonal allergies, and all of a sudden starts to cough or starts to have nasal congestion, that's a time to be suspicious. If this is a child who's gone through his or her entire life with nasal congestion or chronic cough, that's a child in which to say, I'm going to, make sure that I'm paying extra attention. Is this are these child's symptoms expanding, worsening in severity? And these are subtle differences, and they're really hard to implement. But that's the framework with which we think about evaluating kids who may have chronic symptoms and chronic conditions that overlap with coronavirus symptoms.
I would just add that if you haven't seen it, I think the state has adopted a refined sort of guidance around a symptom screener that is a little bit more discerning. So what I mean by that is that respiratory symptoms like cough and shortness of breath sort of all trigger let's think about this child. But runny nose, fever alone, there's a set of symptoms that require 2 or more. And so I think that is helpful and a little bit more discerning, and that's available. I can send that over, or that's available, should be available through the Pennsylvania Department of Health. And I would encourage you to use that framework, because I think that in addition to Susan's very smart guidance around difference from baseline as a helpful framework to think about this, that sort of more discerning framework will weed out children who just have runny nose in the absence of any other symptom.
Yeah,
Thank you very much. That's very helpful.
Yeah, that's a really important point for you folks to consider.
Okay, I do have a couple of questions, and I want to reiterate what Mrs. Melton and Mr. DeBello said. We thank you for your time and for being here tonight and sharing a lot of this. I think a lot of what you touched on is a lot of what we have been working on. I'm happy to say that we have touched on a lot of these areas, and the district has been doing that, and the board has given direction for that to happen. We've been looking at the social distancing, the mask wearing, all of that. Couple of questions though, and I probably am piggybacking more on Mr. DeBello at this point, but in terms of these numbers, can you talk to us about, we've heard lots of information shared about receptors, and in younger children, they don't have these ACE receptors, so they're not susceptible to it. They can't be carriers. Can they or can they not? What age is that? Have you seen, let me stop there and let you answer that before I go any further.
Sure. So there's an extensive and really interesting scientific discussion about the capacity to which children can become infected and why it is that we have some data that suggests they may have slightly less susceptibility to infection. I think right now, though, as people concerned about public health and community settings, our focus really needs to be on these questions that you posed. Can children be infected? The answer there is yes. Can they have large amounts of virus in their nose? The answer there is yes. We've just gotten data that shows they can have as much or even more than adults, even when asymptomatic. And then the final piece is, can they transmit to others? And there again, sadly, we're learning that yes, they can transmit. A lot of our early conversations really focused on, isn't it fortunate that children aren't a big part of this story? Isn't it fortunate that children don't seem to transmit the virus? But the thing that we, at least, I'll say for myself, I did not fully recognize is that our assumptions were based on observations from a period of time when children were doing almost nothing out in the community. They were staying in their homes, playing with their siblings, and had almost no contact. So had almost no opportunity to show us, can they get infected? Can they transmit? Fast forward to the past month or so when children have been going to camps, when children have been returning to schools in other parts of the country that opened earlier, when children have been returning to childcare. And we're seeing that, yes, children can get infected. They can get symptomatically infected. They can transmit, and they can even transmit down to very young ages as toddlers and infants. And so I think what we're finding out is that our past assumptions that children are relatively less susceptible aren't true. Children are susceptible. Children can transmit, and we still are learning about how important their role is. But they do have a role, and they do contribute to community burden.
Is the impact for them more that of a cold as opposed to a hospitalization or a potential death? Is it less severe?
That's a great question. If you take an otherwise healthy child and an otherwise healthy adult of just about any age, or of any age, let's say, the child and the young adult may have relatively similar courses of illness. But certainly as an adult gets older, 40s, 50s, 60s, and because I'm in the midst of that age cohort, I worry about that. And certainly elderly, the likelihood of severe disease becomes much greater in an older adult cohort than in a child cohort. Many more older adults are going to get hospitalized than children.
And can it lead to other diseases, or was that a rumor that had circulated in the media? Because there were conversations about, I think it was Kawasaki disease and some other complications. Would that be due to somebody having, say, a pre-existing condition before they contracted the COVID?
So I think the question you're alluding to, can coronavirus be associated with other diseases, is one it's still a little murky, But a couple of things we can say is that yes, a very small subset of children seem to progress from having a mild or even asymptomatic coronavirus infection to having a multi-system inflammatory reaction, oftentimes that ends them up in the hospital and sometimes critically ill. This new syndrome, fortunately, happens very rarely. We've seen it less than 50 times at CHOP over the course of the past 6 months. But that's, of course, 50 times too many. And so coronavirus is not 100% benign illness in children. And then obviously, there's the emerging understanding that children with coronavirus likely contribute to community coronavirus infections.
And I'll just
much
add,
like Mr. DeBello asked, the numbers there, that 10,000 and then the 861, do you have a break? I know he was asking about nursing homes and veteran groups, but do you have any numbers at all to say what portion of those numbers are under the age of 18?
Meredith, you want to respond to that?
yeah, so
ballpark numbers.
So ballpark numbers, it's small. I think we have seen in Montgomery County, I would guesstimate that about 5 or 8% of those cases have been among children less than 18. And as Susan's mentioned, a smaller proportion of them have been symptomatic or symptomatic requiring hospitalization. I think the point that I just wanted to sort of touch on related to this conversation is, as Susan mentioned, we are learning more every week, and I think what we've learned most recently about the amount of virus that children can carry in their noses leads us to believe, and we've seen some evidence about children playing a role in community transmission. And when we think about schools as a community and sort of a smaller community, part of a larger community, I think what we know now, or sort of know more now to confirm what we thought, is that yes, we need to worry about children, but we also need to sort of view the full school ecosystem as children potentially playing a role in transmission to the adults in the building and potentially back to their homes. And so I think it's very important to understand the risk to children. And certainly as pediatric health experts, that's sort of where our mind is at, but also to not lose sight about sort of the school community as a whole and the sort of bi-directional risks that exist between adults and children and adults.
Absolutely, and I think that brings me to my next question and the one I started with about the contact tracing. So with that, we are aware that the school is going to have seating charts when we get back, and busing will be, all of that will be orchestrated so that they could then share that information, communicate that information with the county, and that they would then take the lead on what to do there, as so we've been told. My question is, what is that lead? That's the information we're really looking for tonight and need to have this answered. What is the lead? What is that communication? Who has to quarantine? How long do they have to quarantine? Is it just the student that is symptomatic? Is it the students that have been in the class? The students that rode on the bus? Is it the teacher? Is it the family at home? That information we do not have. What's the time frame? Who's involved? Once that communication has taken place, do you have information on that for us?
So I can start.
It is turned to the county. I understand it's turned to the county. What is that county information?
Yeah, so I mean, first, kudos in going the steps to actually having the seating charts and assigned seating on transportation and all of that. I mean, that is phenomenal from a public health perspective in being able to quickly provide the county the information that it needs and very rapidly understand sort of the social networks for consideration of quarantine. When we think about who needs to be quarantined, and I'll turn this over to Susan in a minute, but maybe just to tee up for you, Susan, the importance of this concept of direct versus indirect exposure, which I think has been giving a lot of anxiety to folks when they think about the potential scale of who might have to quarantine. And in reality, I think it's much smaller than the worry that people have. And that is due to this concept of direct exposure versus an indirect exposure. So with that, Susan, if you don't mind, I can turn it over to you to talk about quarantine.
Sure, sure. And so, as Meredith said, we can have what we think of in lay terms as an exposure if we were on the same bus, if we were in the same classroom, if we passed somebody in the hallway. However, in public health terms, there are actually kind of crisp definitions of what is an exposure, and that is being within 6 feet of somebody for 15 minutes or longer. And so what I think you'll find is that your public health partners will be asking you those questions. We need your help identifying those people who may have been within 6 feet of the individual, the teacher, the staff member, the student who's now testing positive. And through, as Meredith said, your seating charts, et cetera, you'll be well prepared to participate in the way public health hopes you will participate in giving them the information. Once you've turned that information over, I think in large part, your work will be done. That is the transition to the public health workers at the county level to take the ball and run with it. They'll interpret that information. They will likely interview the first case and try and get a real understanding exactly when did symptoms start, what are those activities that you may have done in the day or so before symptoms started. Tell me more about who you played with on the playground, who you had lunch with in the break room, etc. And from that, they will make the critical decisions on who we need to consider having had a direct or concerning exposure. And it is that decision that will lead to the quarantine of people. But as a school, your role ends with the sharing of information. They have to take on the responsibility of making the decisions and doing the information gathering from there on.
And I do think that the contact tracing will be enhanced by what the administration is proposing in terms of the seating charts. And I do understand that direct exposure is equal to being within 6 feet for longer than 15 minutes. But my question is that the community has some concern, for lack of a better word. What does that translate to? What does that specifically mean? So if someone has direct exposure, what are the quarantine implications for that student, the other students, the teacher, the parents? That's it would be based on, right, so that direct exposure could then mean potentially 14 days of quarantine for a family. Yes, I mean, yes. That's what I'm asking, because that's where the confusion lies.
Okay. So there are two ways to think about this. After somebody's had a direct exposure, they will be at risk of developing symptoms up to 14 days after that direct exposure ends. So yes, you're right. A period of quarantine is 14 days in duration for this virus. There is a strategy, and it will take more investigation and discussions with Montgomery County to see whether or not they're ready to embrace it, of doing a test for somebody who has been exposed and remains asymptomatic for 7 days, to see whether or not they test positive at 7 days or longer after the exposure, in order to allow them an early return to school. That is a decision, though, that we as external advisors cannot really make on behalf of the county.
Oh, and I guess the point that I struggle with is that the kids are currently involved in activities, events, social gatherings all over the entire Montgomery County, because we're only speaking about Montgomery County. So there's, from a contact tracing standpoint, how does the county take all that into consideration as far as, because we have kids that could participate in some type of athletic tournament on the weekend.
Go
ahead, I'm sorry.
No, I was just going to jump in and say, again, that is part of the case investigation interview. And so there's quite an extensive interview process that goes on to walk people through all of their activities from the very first day that it is even possible they were infectious up until the point they started their isolation upon knowing that they were symptomatic and or infected. And so that is the initial work of the contact tracer, is to get the names of all possible contacts and to determine which of all of those names are actual direct contacts and exposures. And then that leads them to their subsequent work. It can definitely and will definitely lead them to areas of the county outside of your township. It will also lead them to other parts of Pennsylvania and outside of the state in their partnerships that cross jurisdictions that facilitate that contact tracing. Again, the good news is that's not your responsibility. It's a big challenge, a huge challenge for public health, but it is their responsibility.
I would love to see that in action, because I've coached a lot of kids and they couldn't even remember what they had for breakfast. So I'd love to see the interview process.
Yep, parents will likely be critical. And just like we're seeing with the college campuses and frat parties, this is something that we really have to help our students understand is super serious. This is not something to blow off, to hold back a name. If you had a unexpected connection with a buddy when you weren't supposed to. And so I think we as adult members of a group of teenagers in particular's world, we need to really motivate them to be as forthright if they are involved in one of these exposure events as possible.
I have to follow up on the contact trace. I have two quick other questions. One is that has there been any reported cases that have been contact traced back to daycares or like the local YMCAs and that are seeing, in some cases, hundreds of kids?
I don't know about the number of kids, secondary and beyond cases, but I think the quick answer is yes. We've already seen through contact tracing across the country, things traced back to almost every possible setting. Definitely to daycares, definitely to gyms, to bars, to restaurants, to outdoor events, team sports, all of the above. So anything that gathers people is a significant risk to being a spreading event.
And last question is, from my perspective, has there been, because we just recently heard of the one football team that was tested positive and then they all just tested it was false positive. Are we getting better statistics or better percentages of understanding the false positives on the test cases?
There often are very specific reasons why there is a significant cluster, like the one you described, that has led to a group of false positives. When false positives happen, they are typically few and far between. There are some well-reported and advertised cases where there's been a big cluster, where there's been a lab issue, some sort of a mix-up that typically are quickly addressed. Overall, I think we are in a position to not doubt our positive test results. And I would be very concerned if anyone disregarded a positive result and said, it's probably just a false positive.
Sorry, I have a few questions, but I would first like to start off by saying thank you so much for talking with us and giving such helpful information. You stated again that there was over 10,000 cases. Just to clarify, these cases were over the 6-month period while we were in quarantine as well, correct?
Yes.
So is there a predicted numbers of if we were to go back to school and more things open up and stop social distancing, what the cases would go up to or down?
There are some models, some of which Meredith actually has helped to build, that try and project forward. Meredith, do you want to comment on projecting the future as using modeling data?
Sure. I think your question is really getting at sort of what do we know about the impact that social distancing and some of our sort of mitigation efforts have had on cases. And I think we have enough data now from observing places that have opened up or rolled back one or the other of their mitigation strategies to know that all of these things do contribute to a rise in case incidence. And so I don't have an exact number for you about what that 10,000, might turn into over the next 6 months if we open schools and selectively roll back all of the sort of good protections that we've put in place. But I can say fairly confidently that yes, we would have a rise in case incidence.
And then, sorry, I have like 3 more questions after this. On a purpose of herd immunity, I think for United States or worldwide, for coronavirus, it's around 93%. Is there an average percentage of what our county has to get to for herd immunity?
So the question of herd immunity is an interesting one, and right now strictly theoretical. To date, we don't know enough to say that there are specific communities that have a different expectation than any other community. The estimates range from as low as 60% upwards to over 90%, like you cite. So.
And then my last 2 questions are mainly more about the virus, just so I have a better understanding of it, as well as the board, of course. Has there been any cases of co-infection with coronavirus?
Yes, there have been many cases of reported co-infection where children and adults have a second or even sometimes a third virus detected.
Is there a percentage of how many total cases of total cases of corona?
I don't have that memorized. It's all related to small data from a whole bunch of different places, and so we could probably calculate it if we brought together all the studies. I don't have that number right now.
And then my last question. I don't know that much about science, so this may be very invalid, but has the virus been categorized as either like going through the lytic or lysogenic cycle? I tried to look for articles and I couldn't find anything.
So the details of the viral life cycle are probably not super important to the questions of school transmission. And while I definitely would encourage you to pursue it, the science and the life cycles of viruses are fascinating. I don't have an answer for you right now. I'm sorry to say.
I just, in relation to the school, I just want to see of course the virus is dangerous, but to what extent when opening up schools. So thank you.
Yeah, of course.
Well, thank you very much.
To share with folks, Meredith and I probably need to just have another 5 minutes or so with you in order to return to other commitments, since this is on top of our day jobs.
Yes,
so
absolutely.
I think up around 9. Does that sound good?
We're done. That's what I was trying to say. I felt badly that I knew there was a shorter time frame allotted. So thank you for going over, and thank you so much for sharing with us. We're done. We won't hold you any longer, and we appreciate everything and hope that you stay safe. Thank you so much.
Very good. And to you folks, appreciate your questions and best of luck with the upcoming school year. We're rooting you on.
Good luck with everything.
Bye-bye.